everyone. Good evening, good afternoon, or whatever equivalent you might have from where you're watching right now. Welcome to the Multiple Sclerosis Association of America's live webinar, What's New in MS Research, a look into the future of MS treatment. I'm Kyle Pinion, Senior Director of Education, Healthcare Relations, and Advocacy for the Multiple Sclerosis Association of America, and your host for tonight's program. Hooray! On behalf of MSAA and our presenter, we greatly appreciate the opportunity to keep you updated on this very important topic. And please know that we hope you and your family are staying safe and healthy in these uncertain times. MSAA is extremely honored to host this educational program with Dr. Barry Singer, director and founder of the MS Center for Innovations in Care at Missouri Baptist Medical Center. As I'm sure you know, MSAA is a national nonprofit organization dedicated to improving lives today for the MS community, now in over a half century of service to this incredible population. Some of our free services include a national helpline, equipment and cooling products, MRI funding, an online community, webinars, and many more free programs available to people living with MS all across the country. It's free. You can't beat that. Also, please know MSAA has expanded our helpline hours to 8 p.m. Eastern between Mondays and Thursdays. To learn more about these and all the ways MSAA improves lives today, please visit mymsaa.org or call 1-800-532-7667. And one quick plug, we have a brand new publication called It's a Generational Thing, a toolkit designed to aid communication between parents and children, be it a parent living with MS or a child living with MS. And we think it's something you'll find very valuable and a perfect complement to our already wonderful Mommy and Daddy Stories booklets. Please check it out on our website when you get a chance. I think it is fabulous, and I think you will too. Additionally, I wanted to draw attention to our brand new virtual display hall, which you probably heard us discuss a little earlier before the program started. This has been made available thanks to the generosity of our selection of sponsors. If you haven't already, please take a minute to click on the link in the chat box to visit this new and exciting information portal, which showcases the products and services offered by our sponsors. And we want to thank our friends at Biogen, Genentech, and Sanofi Genzyme for their incredible support. And lastly, please know that tonight's program will be archived to our website very soon. For our Q&A session, please type your questions into the Q&A box and we'll address them at the end of the presentation, time pending. I will tell you, we received so many wonderful questions at the registration process time that we may not get a chance to get to all your questions. But we're going to do our best and certainly hope to be able to address them in a timely fashion. Also, if you have any technical issues at all, please type those concerns into the Q&A box as well. And lastly, when the program is over, please make sure to fill out our survey, which may already be populated on your screen, but we'll also link it in the chat box so we can get all of your opinions and thoughts and making sure that we develop programs that are relevant and interesting to you as someone living with MS or a loved one supporting a member of this community. Now, we are so pleased to have you join us for this timely conversation. And I am honored to introduce Dr. Barry Singer. Dr. Singer earned his undergraduate degree from Duke University and his medical degree from Columbia University College of Physicians and Surgeons. He completed his residency training in neurology at New York Hospital, Cornell University, and a neuroimmunology fellowship at the National Institutes of Health. Dr. Singer is the director and founder of the MS Center for Innovations in Care at Missouri Baptist Medical Center in St. Louis. He is an associate professor of clinical neurology at Washington University School of Medicine. He has been an investigator in greater than 35 multiple sclerosis trials focused on new therapeutic options, including remyelination. So I got to tell you, we got the right guy for this talk. He serves on the board of directors of the Multiple Sclerosis Association of America since February 2016 and has a position on its executive committee. Dr. Singer has received a congressional proclamation for MS research in 2008, and his award-winning MS patient education website, www.mslivingwell.org, I'm going to say that again, www.mslivingwell.org, started in 2007, has been a valuable resource in 200 countries. Dr. Singer is also the host of the MS Living Well podcast, which you can find on iTunes, and I even found on Spotify. So if you're a subscriber on Spotify, check that out. I'm so happy to introduce my good friend and one of the greatest advocates for MS care in the world, Dr. Barry Singer. Hey,
thanks,
Dr.
Kyle. Hey, thanks so much for inviting me. It's great to be with everybody this evening.
Yeah, no, it's fabulous to have you. And thank you so much. I hope you had a great 4th of July holiday.
Yeah, I was on call. Actually, I was covering the hospital, but that comes with the territory. So that's part of being a doc.
Yeah, I get it. But thank you for all your service for the MS community and beyond. Now, before we get started, I just want to explain how this program is going to work. This is going to be a bit of a conversation between Dr. Singer and myself, which would make this, I think, pretty fun. Consider me like your Conan O'Brien to Barry Singer's celebrity guest, if you will. But before we get started, we do have a polling question that I want to get us all sort of excited and revved up for first. So the very first question I want to ask is, which superpower, if you could have any superpower, would you like to have? I'm going to launch that now. I'd love to see what y'all's feedback is on this. This is just a fun warm-up question. I already know what I would pick, Barry. I got to be honest with you. It would definitely be super speed for me. It'd have to be. Mostly because I can get. What were you?
I think I take flight. I think I take flight.
You know what? I got to tell you, based on the results I'm seeing, that it seems like most people would pick that too. But with super speed, you can go into the past and you can like go and mess around and to time travel. I've watched enough Flash on the TV to know what all the fun stuff he gets up to. So
if you're living with disability, I could see flying would be kind of solve a lot of problems there.
Yeah, but
physical disability at least.
Sure, super strength would be fun too. Actually,
yeah,
man. All right.
I think we should have a ride in here.
I know. Well, with a minute to go here, I think we've gotten quite a few votes. So I'm going to end the poll here, and here are the results. Let's take a look at them. Look at that, flight and super strength tied. So we've got some real diverse perspectives on the superpowers people should have. Right. Thanks for humoring me, folks. So let's get started, and let's actually get to the fun parts of the conversation. And let's talk a little bit about the most recent FDA-approved treatments for MS. Dr. Singer, what are they, and what can you tell us about them?
Yeah, so for the past 3 years, we've seen incredible progress in terms of the amount of options. In fact, it's almost dizzying amount of options when you have a newly diagnosed patient sitting in your office and we're talking about where do we go. But it's great to have all these new options. When you think about it, there was no treatment before 1993, and the first oral didn't even get approved till 2010, FDA approved. So now we have an array of options. So let's kind of dive in. Most of these are for relapsing forms of MS. So this would include people that had their very first attack, let's say optic neuritis, visual loss in one eye, with lesions on the brain consistent with MS, relapsing remitting, people having attacks and getting better, and then those that are slowly getting worse, secondary progressive. Most of the drugs are approved for secondary progressive that still has relapses or still has MRI activity. So you're more in the progressive phase, but there's still relapses or new MRI activity. We call that active secondary progressive MS. So what are the new options? So one class of drugs that we have are called fumarates. So many of you are familiar with Tecfidera and the generic version, dimethyl fumarate, that got approved. But we have actually two new compounds in the same class. One is Vumerity, and Vumerity tends to have as diroximel fumarate, and it's converted into dimethyl fumarate, which is the active ingredient of Tecfidera. And the advantage of it is less gastrointestinal side effects. In fact, I was involved in the clinical trials, and we found that less than 1% of patients discontinued the gastrointestinal problems on Vumerity compared to about 4.8% of patients on Tecfidera. So a little bit better tolerated fumarate. And then there's a monomethyl fumarate, which is Bafiratam. It's also just got approved as well. So we got diroximel fumarate, dimethyl fumarate, and monomethyl fumarate. Another big class of MS medications that's kind of exploded are called the S1P medications. And these are oral medications that can be taken once a day. Many of you are familiar with Gilenya, that's been around since 2010. One downside with Gilenya is you had to monitor people for 6 hours doing blood pressure and pulse check when you first start because of rare heart rate issues. And so we had to monitor patients, but we don't have to do that with these new options. They all start with a titration up. One of those compounds, the first one that got approved is Mayzent, and Mayzent was studied in progressive patients. So these were patients that are generally a little bit older than our relapsing remitting clinical trials. 56% of people needed assistance. The age went up to 60. So we looked at an older population that was more progressive. Actually, very few patients, a very small percentage of patients were having new active lesions or new relapses. And it slowed down the progression in that group of patients. So positive in the secondary progressive category, approved for active secondary progressive MS, relapsing remitting MS, and clinically isolated syndrome. There's two other S1Ps. One is called Zeposia, and Zeposia not only is approved for MS, it just got approved for ulcerative colitis. And I got a few patients that got both. So now they got one option to kill two birds with one stone.
Wow.
And this clinical trial, it was compared against Avonex. There was a couple trials. In the 2-year trial, it reduced new relapses by 38% compared to Avonex. And then the most recent S1P approved is Ponvory. And Ponvory is a once-a-day pill as well. And it was compared against Aubagio and cut relapses by 31%. So it's great to have 3 new options in the S1P class. Now I'm going to transition to, go ahead, Kyle.
No, I was just going to ask, I mean, there's so many therapeutic options, and I feel like with 19, I think it's 19, not counting generics. How does a physician choose the right one for the right patient at that time? I just feel like, sorry, you go ahead.
Yeah, so a lot of it, we have to kind of look at the disease, so does someone have very active disease, are they having lots of relapses? Is someone with more relapses early in the disease course, we may get a more aggressive treatment. If you got a lot of lesions on your brain, we may want to take something that may be more highly effective than someone that has 2 or 3 lesions in the brain and maybe nothing in the spinal cord. So we look at the disease, how active is the disease. We also have to look at the individual. What's your where are you? Are you someone that's ready to have a baby and maybe coming off treatment, or do we need to find something that you can take actually during pregnancy? Is this someone that's 60 years old and you have to worry about the immune system not being quite as robust and there's an increased risk of infections or maybe even cancer? So we have to kind of look at the individual. Some patients, unfortunately, we know that African-American patients are at increased risk for disability. So we may want to be more aggressive with treatment, and men tend to do worse. So we try to look at who the individual is. So all those factors come into play. We also look at other medical conditions. So sometimes if you have GI problems, one class may not be good. If you got diabetes, or maybe a risk with another class. So we really look at the medical issues as well. And then the final couple, I want to mention 2 other new medications that are out there. One is Mavenclad, and that's a oral medication. You take it for 4 or 5 days, a month goes by, you do it again, and then you're good for a year. You do it again year 2, and then no treatment in years 3 and 4. And that reduces relapses by about 58%, kind of resetting the immune system. And then finally, we have Kesimpta, which is very similar in terms of how it works as Ocrevus. Some of you are familiar with that. And it's instead of an antibody in the IV twice a year, you do an injection once a month under the skin at home. And this was very positive. It reduced relapses by 51 to 59% versus Aubagio. So a lot of different options out there. And so it's really important that you know about your options, but sit down and your neurologist may kind of still, kind of shrink those options down to 2 or 3 and talk about pros and cons that might fit for you.
Sounds great. But I guess in the look of the future, looking into your crystal ball, I'm curious about what treatments are in development for, I guess, we'll break them down into the two blocks of MS. I mean, even though there's 4, but we'll just say relapsing and progressive. Let's talk about relapsing first. What treatments are in development for folks who have relapsing remitting MS right now?
Sounds good. Why don't you hit the next slide for me? There we go. So yeah, we rehearsed this sort of. So relapsing disease. So are there new therapies for relapsing disease? So there are a lot of things in clinical trial and development. The one that's probably that the data has already been out there presented is another B-cell depleting medication. So it's an antibody infusion twice a year. It's got a big name called ublituximab. And so ublituximab was also compared against Aubagio. And so it's easy to go against an oral once a day, in terms of oral once a day that's well tolerated. So it's easy to set up those clinical trials. If you look at the patients on ublituximab, it dramatically reduced active contrast lesions in the brain by 96 to 97% compared to Aubagio. And it is important to keep in mind, Aubagio already prevents 80% of lesions. So this is 96 to 97% better. 1 hour infusion, which will be very convenient for patients. So they come in the infusion center, and after the first one, which is more prolonged, after that, it's a 1 hour infusion every 6 months. So very convenient. Then we have another class of MS medications. It's being studied across the spectrum of disease, from relapsing to primary progressive to secondary progressive. And these are called BTK inhibitors, or Bruton kinase inhibitors. And so these BTK inhibitors affect 2 cells. One is the B cell. But instead of knocking out B cells for 6 months, it's a more shorter acting. So potentially, if you discontinue the drugs, the B cell function can improve. But these BTK inhibitors also target a cell called microglia. And microglia seems to play a role in progressive disease. So we see in people with MS, inside the brain and spinal cord, there's some lesions or MS plaques that are still smoldering inflammation around the rim. So around the rim, there's this group of microglia cells that are causing inflammation. And so these drugs really not only target the B cells, but also target the microglia. So there's some hope that these drugs may help slow down progressive disease. So the ones that are looking at relapsing MS right now are evobrutinib, which was studied in a phase 2 clinical trial, and the 75 milligrams twice a day dose seemed very effective on reducing new active lesions and a trend on reducing relapses. And so that's headed into a phase 3 clinical trial program. And then tolobrutinib was also studied in phase 2 trial, and it prevented about 85% of the active lesions on the brain and 89% reduction in T2 lesions. So very robust results, and that is now being studied in relapsing MS, secondary progressive MS, and primary progressive MS. So some of these agents are out in a lot of different options. One last relapsing trial that's out there is there's a medicine called a neuropeptide combination of 2 compounds. It's called Ncortin, and that's in phase 3 clinical trials. So there's a lot of some new options for relapsing MS. We got a lot of options for relapsing MS as it is, but there's some new options for relapsing MS.
So on follow-up to that, earlier on you mentioned one particular therapy which had benefits beyond delaying progression. I know Zeposia is one of these the therapies that has kind of multi-factor benefits. I'm curious, are any of the therapies that are in development have that same sort of benefit for patients?
Yeah, so we're definitely looking at across the spectrum, not only, so the original outcomes that we looked at in the clinical trial, so many of you that are familiar with the traditional drugs for MS, the interferons, and what we always looked at was the reduction in new relapses. Does it slow down the progression of disability? Does it prevent new MRI lesions? Some of these new agents, what we're really looking are, we're going beyond that. One of the things we're concerned about in MS is the brain tissue can shrink over time. And we know this happens at a faster rate. And typically with MS, this happens somewhere between 0.5 and 1.35% per year. So there's definitely some brain shrinkage. And many of our new medications, we're looking at preserving that and preventing brain shrinkage, which can affect you cognitively and physically. So really the goal is some of these medications, we're looking at brain volume. We're also looking at something called NEDA, which means no evidence of disease activity. We're trying to stop relapses and new MRI activity and disability. in my office, I like to call it boring. I want boring visits. I want nothing going on. MRI's unchanged. They're not getting worse. Everything's good. So NEDA, no evidence of disease activity, is another thing that we're looking at. And even in clinical trials, we're also looking at clinical disability improvement. So we're seeing in some of our highly effective medications that things are actually improving over time. So that's definitely some of the outcomes that we're looking at. It's not just the traditional ones that we originally were looking at. So now the bar is being set higher. Can we get better outcomes?
Good.
I think the other big area so one of the other things we're looking at is how can you intervene earlier? And there's some new concepts looking at this. One is, it was interesting, in the University of Calgary, one of the insurance companies was not covering, after your first attack with lesions in the brain, they were not covering treatment at that point. So they came up with a trial. They're looking at minocycline, which is an old antibiotic that has not only has some anti-inflammatory benefits and has been around for a long time. It's actually used for acne. And so minocycline is now, there's some preliminary trial data that shows some positivity. And so now it's being studied in a larger trial at University of Calgary to see, does it work to prevent conversion into definite MS? So it would be great to have an inexpensive, easily accessible medication globally to prevent conversion into MS.
No kidding. Wow. That's incredible. Let me ask you though, on the progressive side, I'm sorry, I don't mean to interrupt if you're still.
Oh, no, go ahead.
I'm curious about on the progressive side. I know we have Ocrevus for primary progressive patients,
Right.
but is there anything new that's being developed for that particular population?
Yeah, so particularly for the primary progressive patients, there are some clinical trials. It's actually, before I prepared for this, I went and looked at clinicaltrials.gov, great website, and you can see actually any clinical trial. You can find out what sites are recruiting for the clinical trials. But over 400 clinical trials globally are now actively recruiting for people with MS to participate on an array of, not all of them are, like interventions or medications. Some of them are monitoring disease and looking at disease. So for the primary progressive MS, there's a few trials specifically for the PPMS. One is, two of them are in that BTK inhibitor. So one is tolebrutinib, and there's another one, fenebrutinib. And so these are, because they affect that cell, that microglia that causes that smoldering inflammation, there's some hope that these drugs will help slow down primary progressive MS. And as you mentioned, Kyle, only Ocrevus is now, FDA approved for primary progressive MS, and that was based on the Oratorio trial. There is glatiramer acetate, which is Copaxone. There's a form of GA that's being injected monthly, and that seemed to have some promise. And then we have a group of drugs that are looking at, they're being studied in both secondary progressive and primary progressive MS patients. So there's a lot of overlap in these secondary progressive people without relapses to primary progressive. Things are slowly getting worse. And so there's some options there. One of them is being studied in both populations is lipoic acid. And so lipoic acid has anti-inflammatory and antioxidant properties. And so there's a study going on right now in about 119 patients looking at lipoic acid, which would be inexpensive, easy, hopefully trying to slow down the progression. There was also a data in a pretty large trial of an oral medication called masitinib. And masitinib was studied in 301 patients, and it really reduced the likelihood of disability progression. And so that's an exciting compound that's now going into a larger clinical trial. So another exciting advancement.
Outstanding. I know you answered this a little earlier, so forgive me. I want you to reiterate it though, because a few people have asked this question in the Q&A, and I think it's important. The FDA has approved certain therapies for secondary progressive MS and others for what's termed as active secondary progressive MS. How do we define the latter? And can either therapeutic option be a benefit to patients with primary progressive MS by chance?
Yeah, so really everything that's approved right now is for active secondary progressive MS. So okay. None of them just say pure secondary, the drugs that we have available are now pure secondary progressive MS. I think the closest one, if you look at the data from MAZENT, from the EXPAND clinical trial, most of the patients were not active secondary progressive MS. So what's active secondary progressive MS? So let's say your leg is slowly getting weaker, your balance is a little worse, You're slowly getting worse over time. Where you were 6 months ago, a year ago, you could see slow progression, but you still have a relapse from time to time. You still may or may not have new MRI activity. So it's active SPMS as if you're still having new MRI activity or still having relapse of superimposed. The hard thing is if you're on treatment, so you're started on an MS medication, you may be suppressing some of that activity until you stop it. You don't know if you're really active SPMS or not, and that's a challenge in some countries. Trying to make a decision with an individual patient. But those are the drugs that have been approved are really for, say, active SPMS to shut down that inflammation. There are some other very exciting fronts for secondary progressive MS. One of them is simvastatin, which is cholesterol drugs have been studied in MS for actually a lot of years. And there was a trial adding it on to Rebif and Avonex back in the day. But there's a very large trial going on right now with over 1,100 patients in the UK looking at simvastatin, a cholesterol statin medication that has anti-inflammatory properties. And so hopefully that may show positivity, and that would be an inexpensive trial. And there's even like a cool clinical trial looking at, it's called T cells, which are one of the immune cells, T cell receptor vaccination. And so there's a trial with that. And the idea with the vaccination is you're trying to create cells that are suppress autoimmune disease. So there's cells called regulatory T cells, and they keep autoimmune disease in check. So this is a vaccine to pump up these regulatory cells to keep autoimmune disease. So this is being looked in secondary progressive MS. So there's definitely quite a few things that are going on, some interesting approaches to trying to control SPMS.
Wonderful, wonderful. Well, let's talk about the hottest ticket in town. I feel like every time we have a talk like this, everyone wants to talk about remyelination. And I think that really does hold a lot of promise for patients. But how is that research going currently?
Well, there's pros and cons. I kind of look at it, there's battles and then there's a war. So I think this is doable. I think we can definitely stimulate myelin. There's cells in the brain called oligos, and those are the mature cells that make myelin. So we know in the brain and spinal cord, 5 to 8% of the cells are these immature myelin making cells called OPCs. And these immature cells, the idea is to turn them on, recruit them into the plaques, create new myelin. So there's been approaches with that. In fact, I've been involved in 5 clinical trials where we've tried antibody therapies to try to stimulate remyelination. One of them was opicinumab, which was studied in a number of clinical trials with some early evidence that it might work, including in optic neuritis, but that another clinical trial failed, so that's not going forward. And then I was also involved in some phase 1 clinical trials, early stage, with a compound that was developed at the Mayo Clinic with Rosas Rodriguez called RHIGM22. So we've been trying some things early on, but the antibody therapy, so far, nothing's hit. There are a number of exciting advances though going on in clinical trial. One of them is a clinical trial looking at 150 people that have optic nerve damage, and they're giving them nanocrystals of gold. So the idea is gold therapy, and it's oral. And actually there's animal models that it can get in and stimulate, turn on the metabolism of oligodendrocytes, these myelin-making cells in the brain, and make myelin. So pretty cool. So there's a trial going on with 150 people with crystalline gold. Then there's a trial on myelin remyelination out in Portland at the Oregon Health Science Center, Health and Science, and they're looking at stationary exercise bikes and seeing if aerobic exercise actually stimulates myelin production, and they're doing some electrical tests to show that. And speaking of electricity, in Paris, which is France, is a big area of remyelination research. They're actually giving electrical stimulation right to the eye, outside the eye, in people that have optic neuritis to see if that can stimulate remyelination. And then we have compounds they're looking at. Actually, there's some evidence that testosterone increases remyelination. So there's a study in France of injecting testosterone. I assume this is in guys. It doesn't say on the clinicaltrial.gov website, but they're injecting testosterone to see if that increases remyelination. And then finally, a center that's done tremendous amount in the field is at University of California, San Francisco. And Jonah Chan has done these cool little, he's created these micropillars, which are like cones. And you stick one myelin-making cell, immature myelin-making cell on top of it. And then these cones, there's called micropillars. There's a whole tray of these with all these little cones. And you can add all these old compounds on, approved medicines, on top of that and see what grows, what stimulates myelin production. And a couple compounds have come out of this. One is clemenstein, which is clemenstein is a anti-histamine medication. So that was studied in optic neuritis, seemed to have some benefits. So that's being looked at. And then basedoxifene is looking in 50 patients, and this is an estrogen modulator. So it's interesting. So now you can find compounds that are out there. You don't have to reinvent or create a new drug, and see if they work in a myelin-making trial.
Wow. Yeah, that's super interesting, especially about the testosterone trial. It sounds like sort of the opposite of the estriol trials from many years ago,
right,
that had always sort of stuck with me. And people are always asking about testosterone trials. So I'm fascinated by people, by researchers kind of diving into that area.
Actually, estritriol is still around. So estritriol
was
looked at added to glutathione acetate, Copaxone back in the day, and it didn't seem to add much benefit. But it actually is being looked at in cognition. And so this is a hormone that's actually produced in the last trimester of pregnancy at high levels. And we know, it's interesting. So women with MS do really well in terms of the MS disease in the last trimester. The disease tends to be quieter. So the idea is to give estritriol to see if it helps with cognition and MS.
Very good. Well, wonderful. So in terms of when we might actually see remyelination produce a type of treatment, or even a more loaded question, what can we actually expect that it might restore for a patient vis-a-vis mobility or quality of life? Is there any sort of long shot answer for that?
Yeah, I think there's two components to it. One, obviously, the ultimate goal, if it works robustly, is you could restore a function, so improving function. That's the great hope. That if you give you can robustly turn on remyelination, you can remyelinate some of these plaques. Many of the axons and the nerve processes are just not covered in myelin. So if you could stimulate that and recoat the nerves, you could theoretically improve function. Another aspect of it is when these long nerves, like some of your nerves go from, neuron goes from your brain, your cortex, all the way down your spinal cord. So some of them are very long and they're covered in myelin. Myelin not only helps electrical conduction down the nerve, but also supports that axon, protects it, and it nourishes it. And so if you lose the myelin, then that nerve over time is at risk for dying or getting injured. And that may lead to progressive MS. So the idea is if you could recoat, maybe you would protect those axons long-term so that when people get in their 50s and their 60s, they're able to maintain their function and not develop progressive disease. So it would also be kind of a stabilizing the disease and preventing what we call neurodegeneration or the loss of the axon over time. So kind of a protector. So both of those are reasonable goals. But you just got to keep slugging away. So we need for those pharma partners that are tuning in tonight, we need you to invest in remyelination. And I got the patients, and I'm sure plenty of you out there are eager to sign up for remyelination trials. So we all have to partner together to try to advance the ball. But I think this is doable, and I think we're going to find something that's going to help remyelinate.
Hear, hear. Well, to pivot to symptoms, talking about MS symptoms is its own presentation in of itself. But in terms of recent advancement in managing MS symptoms, are there any particular highlights you'd love to discuss?
Yeah. So I can talk about some of those trials. You want to flip the next slide? So, polling question. All right, here we go. So there's tremendous amount of symptoms that, and I think one of the best things I do, particularly patients with more progressive MS, I think one of the greatest things that I do in the exam room is work on trying to improve quality of life. And there are many symptoms of MS that we can do things about, spasticity, nerve pain, fatigue, so there are a lot of things we can treat. And so there are a lot of research going down on looking at different options. One of the cool trials that's going on, fatigue is like number one. 90% of people with MS have fatigue. So there's a trial going on called Combo MS. And there's a growing data that people that get cognitive behavioral therapy can actually reduce their fatigue level. And so there's a lot of clinical trial data that shows that cognitive behavioral therapy really helps. Unfortunately, there's not a lot of CBT going on right now for people for fatigue. Tends to be, energy conservation, managing it, working on sleep, and then drugs. So this trial, the Combo MS, looks at cognitive behavioral therapy. They look at modafinil, also known as Provigil, and then the combination to see what works the best for people with MS in terms of reducing fatigue. There was an interesting study of looking at fatigue where patients were randomized they started on either amphetamine, amantadine, Provigil, or then they went on to placebo. And all patients took all four different options, and they didn't see a significant difference between all four, which is kind of surprising because many of my patients and many other clinicians I know see significant benefits from some of these medications. A few other things that are being looked at, bladder is a big issue for a lot of patients. And there's tibial nerve stimulators where you stimulate a nerve in the leg to try to improve bladder function. So this is being actually studied directly in MS patients. And for spasticity in Europe, there's a compound, Bixables, which is a cannabinoid product, is being studied, and that's now going into clinical trial in the United States to look at it for spasticity in people with MS. And so there are a lot of different symptomatic treatment out there, medications out there. Unfortunately, we need probably more clinical trials looking at interventions that can work to improve some of these aspects of people's quality of life.
Agreed. It always surprises me too to learn about spasticity, especially because, when about 10 years ago, I learned for the first time that Botox was a treatment for spasticity. And that just absolutely blew my mind, usually considering what Botox is typically used for as anti-aging remedies. It's interesting that it's used for something that's so life-changing as well.
Yeah, I mean, we use actually we use Botox. A lot of patients get it for migraine. So, MS, the average age is, 20 to 40 and newly diagnosed. So migraines are common in populations. We use it for that. We use it for something called hemifacial spasm, which could happen in MS. We use it for bladder urgency. So bladder can be a lifesaver for people with Botox. I saw people today that was just life-changing. They went from they have to wear undergarments to completely dry. So we use it for that, and we also use it for spasticity. So it's used quite frequently. But it's one of our options.
Yeah, that's great. Well, to get away from symptoms and to sort of move into the wellness space, what can you tell us that research sort of informs us regarding exercise and diet in MS currently?
Yeah, so this is a huge area that we really need to focus on, together. And so I think it's very important if you're living out there with MS that you really sit down and talk to your providers and come up with a game plan here. I did that a lot today with my patients. So diet. So what's the right diet for MS? I think this is $1 million question. There was just a recent trial. It was a small trial sponsored. Terry Walls was the lead on that, and it was looking at the Walls protocol, which is like a modified paleo diet, versus the SWANK diet, which is a low saturated fat diet that's been around for a long time. And so they looked at, we started out about 100 patients, but ended up with about 85. And they kind of looked at people on a regular diet, switched onto these diets. Of course, people knew they were switching, but they seemed to have some improvement in and fatigue and quality of life. And then if you follow between the two groups, there was some benefits for walls over the SWANK diet at some endpoints, but it was small, unfortunately, a small study to really prove things. Generally when I talk to my patients, I talk about the perimeter, which means you go in the grocery store, you skip the aisles and hit the perimeter. So I like fresh fruits and vegetables. Dairy's okay, it's got some vitamin D, lean protein, and then skip all the unnecessary carbs and packaged foods. Oh, Kyle's getting sad.
I am very sad.
I don't know what's on aisle 5 for you, but there's something in there.
Candy, cereal,
double
all the things
stuffed,
I like.
I don't know.
Cookies. Yeah.
Little ice cream. Anyway, so diet's important. There's also some really cool stuff on nutritionally being looked at. Intermittent fasting has been shown to have some benefits in autoimmune disease. And here in St. Louis, Washington University, there's a trial looking at intermittent fasting to see if there's some benefit from that. There's also this cool idea that your microbiome, your gut, the bugs in your gut basically affect your immune system so tremendously. And so there's a lot of research going on looking at your microbiome. And even, I don't know about you on the West Coast, you're still having dinner, but there's even a study going on in fecal transplant multiple sclerosis. So this has been used in people with C. diff colitis, which is pretty nasty inflammation in the colon that you could get after being on antibiotics. And so it's a treatment for that. So they're actually looking at it to see if it proves things in MS. So a lot of interesting things going on in that front.
Spectacular. Yeah, I've even seen studies about the Mediterranean diet for MS patients in Italy and the benefits that may or may not have for an MS patient versus.
I think there's a lot of interesting things, and we need more funding for it. So because unfortunately, it's hard to, sometimes this gets not funded as well. And really, to prove things in MS is very hard because you need hundreds of people, if not thousands of people in clinical trials to prove things. So it gets a little hard to know. I have many patients that take supplements. I mean, the one we know definitely makes a difference is vitamin D. And there was a nice trial with beta seron that was looking over 5 years, and people with higher levels of vitamin D had less MRI activity, less relapse, less disability. And you could kind of group them out. There was 5 different groups. And so the people that had the highest amount of vitamin D had the least amount of activity. So having good vitamin D levels is really important. Well,
folks, you heard it here. Lean meats, vegetables, produce aisle, milk. when you're on your Sunday grocery shopping trip.
Healthy living. And really, and then exercise. So next on here is exercise. So exercise is really important. Use it or lose it. It's been a little crazy with the pandemic. I have to say, I haven't been in the gym since March of last year. But many of my patients, it's been a huge issue because can't go to the pool. Some people with a more advanced disability like water aerobics and group exercises, and so a lot of that's been on hold because of the pandemic. So really got to figure out where you're going to go with the game plan. Actually, one of my last patients has just been going through the gym after they've got vaccinated. So you kind of have to figure out a game plan in terms of what works for you. The most important thing is consistency. Show up every day or if you're doing 3 days a week, just keep doing it. Even if you have a bad day and you can't, you can only do the bike for 5 minutes instead of 25 minutes that day. Just get out there, kind of keep doing it. Find what you love, find what you're passionate about. Talk to your doctor, what's a good option. Obviously, we don't want doing things unsafe. So if your balance is bad, don't use a treadmill, use a recumbent bike. Try to figure out what's going to work well for you. The other important thing is brain health. So this is a huge important area. So what helps your brain? Brain is helped by good sleep. If you're not getting good sleep, we need to work on it. Your concentration, your focus is not going to be good. Smoking is a horrible thing with MS. Smokers end up with more disability, both not only physically, but cognitively. So memory, multitasking problems, word finding difficulties, and then it's slowly progressive disease. And I've saw patients today, they really struggle with that. So you got to work on ways to stop the smoking because smokers end up with much more disability. And you can be on a highly effective MS drug, but then you're hurting yourself with the smoking. So really work on that. And then other diseases that can affect the brain include hypertension and diabetes. So we really want to get those conditions under control and really manage those, so that way you can have as much brain health. And clearly we don't want new lesions on your brain. So the more we can control the disease, the better off you're going to do. Exercise is important, as we mentioned. Diet's important. So we really want to keep your brain healthy so that you can age well. And you want to, be involved socially with other people. You want to connect. You want to be, So I think this is all important for positive brain health.
Agreed. And that leads us very wonderfully into our second and last polling question, which I am going to launch now, I believe. Yes, there we go. What type of health and wellness topics are you interested in learning more about? I can't wait to see what people have to say, because this might actually help me formulate our next program topics. So
taming stress. That's an interesting topic.
Yeah.
Taming the stress.
Absolutely. And with 192 folks, I can see everybody. Oh, the results are just pouring in. This is very good. We're gonna get a really great turnout. I'm gonna give it a few more seconds. Here we go.
We'll see if sex wins.
Right now, it is not. I'm sad to say, it is
Intimacy
not.
is a little,
It's a tricky subject. I understand. Well, I think I'm going to end the polling here, and let's share the results. It looks like complementary therapies are the things most people are interested in.
There you go.
With taming stress second, and exercise routines, adapted exercise also that's second, with taming stress third. So that's very interesting stuff.
Complementary therapies. All right.
Yeah.
So we'll have to kind of get into that.
All right. That's something we'll have to talk about soon. Now, thank you, Dr. Singer. We really appreciate the presentation and kind of diving in to a lot of these different topics. What we're going to do now is hop into some of our audience questions, which I'm going to go pouring through. We've seen so many good ones, but I want to start with what I think is the most important one of them all. With 2021 to 2022 being Coach K's last year, exactly how far will Duke go?
All the way. He's got one more for Coach K. Yeah, he's been around for a long time. In fact, I was at college at Duke. He was there, so he's been around for a long time. So it's sad to see him move on, but he's had a wonderful, amazing career.
Well, that was a question from the fine MS specialist out of Santa Monica, Dr. Andy Wu, your fellow board member. I just had
there we go, my fellow board member.
I had to share
that sounds like a Dr. Wu question. There we go.
I'm a Georgia Tech fan myself. So moving on, can you touch on recommended therapies for people over 60? Are there different recommendations for this demographic, such as discontinuing therapy at a certain age and any potential increased risk of cancer?
Yeah, so I think that's really important. Many of our clinical trials have been studied in people under 55. So a lot of the relapsing trials have been in patients 55. I think I mentioned one with EXPAND trial looking at means went up to 60, but most of the trials are looked at younger patients. That said, once the drugs get approved, there's a lot of real world clinical trials. So we look at patients much older. So we start to get some experience once they get on the market. One of the things as you age is called immunosenescence. And so as you age, your immune system is not as robust. So it makes you a little more at increased risk for infections. As you age, increased risk of malignancies, cancers. So we do have to look at the medications. Some medications are safer and have less risk of serious infections like PML, like fungal meningitis. And so some of these drugs have higher risk of these drugs, and some drugs are associated with potential increased cancer risk, at least in the prescribing information. So we kind of look at that, and I think it is important to make that decision. There is a trial going on. It's called the DISCO trial. And so it's actually looking at treatment discontinuation. It's out of the University of Colorado, and is where it started up with John Corboy, and it's looking at, could you take people off drugs? I think it started at like age 55 and up, so it started pretty pretty young. So I think you have to kind of have an individualized discussion with your doctor as a worse discontinuing meds. I tend to keep them going. It's kind of like a insurance policy for me. I've seen relapses as high as people 80 years old. I had at least one patient had very active relapse with new activity at age 80. So you never know when the disease is over. So it is important to have a conversation with your provider. Am I right for treatment? Should I continue treatment? I think the cost thing is going to be better because we've now started to hit some generic medications. So I think it'll be easier for some people out of pocket cost as they age.
On the same subject, similar anyway, are there clinical trials available for older adults living with MS to volunteer to participate in? And where can those resources be found? I think I may know the answer to that question, but
yeah, so clinicaltrials.gov is definitely the place to go. You can search all the clinical trials, and you can search by different ways. But the other places, like if you're going to an MS center, you could also contact them and ask them what's available. Do I fit any profiles, and is this appropriate for me? But yeah, I think there's definitely room for recruitment, and clearly we need to look at all groups of patients. There's some pediatric clinical trials that have been done now as well, because most of the trials were 18 above, so pediatric trials are getting done. But we do need more trials in older patients.
I just want to make a quick plug, by the way. If you visit the clinical trials section on our website, for everybody listening, we have a tool on there that was created with Antidote for MS Clinical Trials Finder. And you'll be able to plug in all your information, and you'll be able to find all the information in terms of clinical trials in your area. So check that out. It's a little more fun to look at probably than clinicaltrials.gov.
Yeah, it's probably easier to navigate.
Yeah.
So check out the MSA's website. That sounds like
I highly recommend it.
Good tool.
So do you have suggestions on natural medicine options for things like fatigue and depression that are complementary to my disease-modifying therapy?
Yeah, so for fatigue and depression, that's tough. So there isn't really herbal supplements that are really, at least proven, as far as I know, to prevent depression or help with depression. Fatigue, probably the most natural one is caffeine, which is, so a lot of people stick with coffee, green tea. The only downside is you got bladder problems and you got bladder urgency. So the bladder gets overactive with caffeine, so it's going to be a double-edged sword. But unfortunately, I wish there was something that would help. I mean, light therapy can help with depression. So that would be something that would be non-supplement, but it's tough. I think one of the things that supplements can make a lot of claims because they're not held to the same regulatory pathway as with the FDA. So it's easy to kind of make claims about what these supplements do, but it is important to sit down, talk to your doc about if you want to start any supplements, and they can let you know this may be fine to try, or this is concerning and may interact with something.
Okay, this is the big topic that's sort of dominated everyone's lives for the last year and a half. Can you share guidance that you might give to your patients living with MS on navigating the pandemic and COVID-19 vaccines, and talk about the general potential side effects from the vaccinations?
So excellent question. I don't know if this is a 2-second question, but the bottom line is get vaccinated. So the vast majority of my patients have been vaccinated, but some days everyone's been vaccinated. Some days I have a few people that have not. So I think at this point in the pandemic, we have not seen an increase in relapses with our patients with MS, and we have not seen problems with our patients with MS. I know at our center, we've had over 200 people get COVID though, and it's been quite serious for quite a few people. So and in fact, so I think it's really important that you talk to your provider about getting vaccine. Really, the only people that wouldn't get vaccinated at this point are someone that has severe allergic reaction to previous vaccines. So there's really not a reason not to get vaccinated at this point. We know the Delta variant spreading like wildfire. In Missouri, we're actually number one. We keep flipping with Arkansas as number one and number two in number of new cases, and I'm still having unvaccinated people get COVID. So we've seen very few. I've had 3 patients that have gotten COVID after vaccination, and they were all mild, and they called us. And we also have an option of antibody therapy that can, that's an antibody that's infused if you have mild if early COVID and you're outpatient, you can get it infused. So it is important to contact your provider if you do develop symptoms of COVID, but get vaccinated. You don't want to take chances. And if your family hasn't been vaccinated, get them in. Generally for my patients, I recommend the mRNA vaccine because it's 95% effective. We know in some of our MS meds, it may bring down the power of that.
Wonderful. Well, and I will just say that the MS Coalition has put out a consensus statement around these vaccines that echo much of what Dr. Singer has said here, really all of it. But we certainly would urge you to check that out as well, viewers. And I will have my wonderful assistant, Alexis, who has been helping me behind the scenes and putting links into our chat box. She'll be sure to link that in there as well for you to be able to easily access before the program ends tonight. Last question. This is it before we wrap things up. What is the current outlook in terms of stem cell research holding any potential promise for breakthrough treatments in MS? What are your thoughts on AHSCT?
All right. So great question. So there has been autologous hematopoietic stem cell transplant, which is basically taking out stem cells out of the bone marrow. You give someone chemo and then you re-inject them, and it's kind of rebooting the immune system. It's been around for a while in the world of MS, and there's been centers all over. Northwestern was doing it, Ottawa, and then across the globe, from Mexico to Russia, all over, there's sites that have been doing this. In general, the results have been very positive. So if you look at the patients that, they've gotten the transplant, they've had very low, we talked about no evidence of disease activity. So a lot of these patients have been doing very well. Over time, though, some patients do break through, and so they start to have new activity. So it's not necessarily a cure for everybody, but for a lot of people do quite well. The big question is now we have a lot more highly effective treatments. So then there's a trial going on called Beat MS. And so this is looking at the best available therapy versus a stem cell transplant. So kind of seeing, how does this really work? And do people with stem cell transplant, if they really do much better, then maybe that paradigm might change. Generally most sites do very well, but there have been some deaths if you pull some of the data together at some sites a lot safer than others. And so you have to be real careful, in terms of site selection if you go to do this. The other area is the other type of stem cells, sort of mesenchymal stem cells. So you can take these out of the fat, out of blood, and then you can inject them. And there has been one good study that's been done in Israel looking at giving them in the spinal fluid and giving them in the vein, and did have some positive results there in a small study, well-designed study. But other studies have not been done great. So you have to kind of be careful of that. I think sometimes people will charge you 10 grand to take some out of your fat and then inject it. And I've had patients get it and then nothing's changed. So I think we definitely need more data, but there is some interesting data coming out of Israel on that front. But I think our minds have to be open to see what's going to be highly effective and kind of look at the risk and the benefit for an individual person.
Outstanding. Well, we're 1 minute past the hour, and I promised everybody I would let them out at 9 o'clock Eastern. So that concludes officially tonight's webinar. I would really just absolutely once again like to thank Dr. Barry Singer for his enlightening and eye-opening insights into the MS landscape. Dr. Singer, thank you so very much for this amazing talk.
All right, thanks, Kyle. I appreciate it. And the MSAA is a phenomenal organization. So if you haven't had time, go on mymsaa.org, surf around, look at all the different resources that are available to you if you're living with MS, including free MRIs for patients that qualify, trying to get diagnosed or having MS. So check out those resources. They really have phenomenal array of tools for you to use.
Hear, hear. Thank you, sir. And as mentioned, tonight's webinar will be archived to our website, and we ask that you take a very brief survey that's coming up next. May already be in your browser. We're going to link to it in the chat box here before you go. We'd love to get your thoughts on tonight's topics, as well as something you might want to see in the future. And please note that we'll be holding programs like this every month for the next few months. So be on the lookout to MSAA's calendar for programs that you will find very interesting and exciting. On behalf of MSAA and Dr. Singer, we thank you so much for joining us. Have a great night, everybody. Bye-bye.
Good night, everybody. Enjoy your summer.